When we look at social differences and wanting individuals to attain or have that ability to obtain their full health potential, we can find the burning platform for our discussion on cultural humility. To increase equity and remove those disparities, we have to have concentrated, focused efforts on individual goals and deliver care that is personal and encompasses an individual's background and their lived experiences. Looking deeper at the trajectory of a health inequity, inequities usually begin with an unhealthy community condition or a structural driver. Those conditions then shape exposures and behaviors for individuals, which go on to inform their medical conditions and health inequities. Culturally humble approaches seek to understand either what shapes the exposure or to understand, particular health behaviors. And that work is deeply personal. So in order to diminish an inequity, there has to be an intense focus on individual behavior and changing what influences that behavior. And culture plays a huge role. Culture can affect one's diet, work life, how one takes care of oneself, how easily one seeks for or asks for help, as well as receptibility to healthcare messages and care plans. So, even thinking about the use of alcohol and tobacco, to some extent that is governed by how culturally acceptable alcohol and tobacco is within a particular group. We know that disparities are numerous and relate to individual behaviors, provider knowledge and attitudes, organization of the healthcare system or access to that healthcare system, and societal and cultural values. So additionally, our traditional broad non-specific efforts, that healthcare has usually taken has proven to be successful for some, mostly non-Hispanic whites, and proven to not be successful for others. And then when we look specifically at tobacco control and cessation, we're seeing that same traditional efforts are well received by non-Hispanic whites and not received to the same extent in racial and ethnic minority groups. So the influence of culture on health, is vast. It affects perceptions of health, illness and death, beliefs about what causes disease, approaches to health promotion, how illness and pain are experienced and expressed, where patients are going to seek help, and the types of treatments that patients prefer. Culture also determines attitudes towards health behaviors. Tobacco control and prevention efforts are put in place to help individuals navigate a tobacco habit or prevent the use altogether. So while there's definitely a gold standard in the eyes of, health educators or health education, behavior change can only move at the pace of individual choice. It is engaging individuals in their cultural worldview and helping to navigate toward a sustainable, healthy future free from the adverse health effects of tobacco use. Practicing cultural humility allows us to engage individuals in their way of doing things, understanding how motivated, what's important to them, and what is their picture of ideal health. And knowing all of that and having that information is ultimately going to help us, with our efforts and knowing what support to provide and what education to provide to the particular groups. So, what are we talking about when we talk about culture? Culture is defined as a body of learned beliefs, traditions, principles, and guides for behavior that are commonly shared among members of a particular group. Culture essentially serves as a roadmap for how we perceive and interact with our world. And as I just mentioned, culture is shaped by many different things. One person can belong to a myriad of cultural groups and have multiple different cultural characteristics. Some of the complexities of culture are easier for us to see and acknowledge than are others. Things like gender, language, foods that are eaten, those are things that we can easily differentiate. But when we think about the role that culture might play on our views of authority, our intrinsic motivation, how and where we spend our time, those things are much more difficult for us to distinguish, and again, are going to vary across different cultural groups. So when we talk about cultural humility and cultural competence, we're looking at, individual and organizational approaches. Cultural humility is having a humble and respectful attitude towards individuals of cultures that pushes us to challenge our own cultural biases, realize that we can't possibly know everything about every other culture that exists, and approach learning about other cultures as a lifelong goal and process. Cultural competence is the ability to understand, appreciate, and interact with people from different cultures or belief systems, especially those that are different from our own. So these approaches require, again, both an individual commitment, but also an organizational commitment, which is why I believe, these terms are used interchangeably, because you definitely have to have both. You can individually practice cultural humility, but if your organization doesn't implement structures that support a culturally humble and competent approach, it's really difficult to create programs or initiatives that can create change for individuals with various backgrounds, behaviors, and experiences. So you'll definitely hear these terms used interchangeably, throughout our discussion today. And really, again, we're talking about an individual commitment as well as a structural commitment to advancing cultural humility and competence. And these, culturally humble efforts are imperative when we put it through the lens of health equity and really wanting to achieve diminishing the burden of health disparities. So according to the Health Equity and Tobacco Prevention and Control that's put out by the CDC, you make the case for health equity by reducing disparities among groups most affected by tobacco use and secondhand smoke exposure, and also addressing the factors that influence tobacco-related disparities. So we have to first understand, which groups are most affected and address the factors creating disparities among those groups. And if you can remember back to, an earlier slide about the trajectory of a health inequity, focusing on health exposures and behaviors can really help to disrupt that cycle of disparities. So this requires us to have knowledge about the groups that are most affected, what's kind of influencing their decisions and behaviors, and additional factors, kind of driving those same behaviors and potentially what individuals are being exposed to. Additionally, cultural competence and humility is central to key concepts we're already exploring in our health services, such as, serving the underserved or having a patient-centered approach and engaging particular cultures or populations. So this is just having that cultural competence lens and structure is just in service of all of these other things that we're already doing and already committed to. So I want to come and ask y'all now, does the organization that you represent have concentrated cultural efforts for tobacco control and prevention? All right, starting to see some of those responses come in. We'll give it just a couple more seconds. All right, so for the most part, it looks like individuals representing organizations here say yes, our organization does have a concentrated cultural effort. So for those of you that said yes, I would love to hear a little bit more about what your organization is specifically doing, and maybe that can give ideas for those individuals who say no or perhaps are unsure. So is there anyone that said yes that would unmute and share kind of what your organization's doing?
Yes, I can share a little bit. I'm with the Boys and Girls Club of Watertown, and a couple things that we do. We run the Catch My Breath program, but we also do Take Back Tobacco Days, where kids do interactive games and activities here where they can learn about the harmful effects of e-cigarettes and ways for them to hand out flyers to the parents and also to friends and families that they know. But it's a really big impact on the kids and the staff as well, just to see the harmful effects of tobacco. And it's through visual aids as well. And we give away prizes for kids that attend and interact with these activities. So it's a lot of work and a lot of fun.
Awesome. Sounds great. And having that concentrated in, like, it sounds like a concentrated focus on youth, have you seen a difference in the uptake of the information rather than if you were just to like provide health education without the concentrated focus?
Yeah, I've seen a lot of change, especially with the kids. They really speak about how some of their parents are vaping or smoking, and they bring awareness to it. And we do have take-home kits for the kids to bring home for their parents and just more information. And we have heard some good stories come from it. The kids tell us that, oh, their mom or dad said they'll try to stop, and the kids really appreciate it, and it shows a lot.
That's awesome. Thanks for sharing. Would love to hear from one more person. What's kind of your organization doing for having a concentrated cultural effort?
I feel I've spoken quite a bit, but I'll share. We do quit kits specifically out with community agencies, and we have those focused on Hispanic as well as Native Americans and other population groups such as youth and e-cigarettes specifically.
When you say focus, what's different than,
The materials are in their languages,
okay. So it's
are
a
are culturally appropriate for their culture.
okay. So you have both culturally and linguistically appropriate
Yes,
materials. Awesome.
yes.
That's great. Thanks for sharing that. All right. So, we've been talking a lot about, reducing health disparities and achieving equitable, healthcare, and that continues to remain an important goal for the US healthcare system. Cultural competence is widely seen as a foundational pillar for reducing disparities. And again, it's due to that having that culturally sensitive and, unbiased quality care. So we're going to look for a little bit here at the different racial and ethnic groups affected by adverse health outcomes from tobacco use. So compared to white smokers, Black and Hispanic smokers are less frequently asked about their tobacco use or advised to quit by a healthcare provider. They're less likely to use tobacco cessation aids to help them quit. And as a result, diverse racial and ethnic individuals who smoke have worse health problems and higher rates of smoking related illnesses than do non-Hispanic whites. And then overall, compared to non-Hispanic whites, non-white smokers report less use of NRTs, less participation in smoking cessation programs, again, less advice from healthcare providers on how to quit, and more unsuccessful quit attempts. So smoking cessation interventions must take these factors into account, when they're designing programs for these racially and culturally diverse populations. So if we pull the lens in a little closer from looking, nationally to looking at South Dakota specifically, we can narrow in a little more on specific priority populations for the tobacco control state plan. So there's 4 areas of focus. youth tobacco initiation, tobacco cessation, tobacco exposure, and health equity. And then there are specific priority populations. So youth under 18 and young adults, American Indians, people with behavioral health conditions, pregnant and postpartum women, and people of low socioeconomic status. So addressing the various initiatives within each of the unique populations is going to really require population-specific approaches, such as appropriate messaging, inclusive materials, and increased access and accessibility. So I want to pause for a moment to ask, you all, what do you think are some cultural considerations you might need to address or consider when we're thinking about the list of priority populations that we just saw? And I invite you to unmute and share, or you can also type in the chat box. So again, what are the considerations? I'll put the priority populations back up for a second, but what are some cultural considerations that we might need to take into account when we're thinking about reaching these specific populations? We've already heard the example of linguistically appropriate materials. So yeah, language and cultural pictures, recognizing sacred and ceremonial tobacco, definitely honoring that for sure. Traditions and culture. Marla adds in age, gender specific teachings. We heard an example of that just moments ago with age specific. Any other ideas about things you might need to consider? We've heard language, we've heard culture. I like access and availability. So thinking about how to reach people, where to reach them, when to reach them. Making presentations fun and engaging for youth, definitely important. Keep their attention, grab it in the first place. Maybe we need a tobacco cessation TikTok dance, perhaps, might get their attention. Awesome. So definitely be thinking about, these considerations as we go forward, and how when we get a little bit more granular on ideas, like where particularly in your delivery or in your organization are you going to need to really dial into these things, or maybe push a little harder on. So just be having those considerations in the back of your mind kind of out as we move along. So we've been talking, on a very high level about what could be considered under cultural considerations. So we're going to take a look for a moment at some specific efforts, what was entailed within those efforts, and further refine what your cultural considerations could look like moving forward. So the first study we're going to look at involved efforts by the North Carolina Quit Line to improve attempts at quitting among African American smokers that were using their quit line services. So researchers wanted to test the effects of a culturally specific video intervention combined with the standard quit line counseling. So each individual that contacted the North Carolina Quit Line received an initial counseling session, and then they could receive up to 3 more proactive counseling calls, each that would be designed to provide practical expert support to help participants develop problem solving and coping skills, secure social support, and design a plan for successful cessation, and then, helping that to be something that was long-term. Participants could also contact the Quit Line as needed for support between the proactive calls. And then finally, everybody was kind of given a 2-week starter pack of nicotine patches, which is consistent, again, with the standard Quit Line care and is provided at no cost to participants. So the experimental intervention in this particular research study was that they wanted to add in a Pathways to Freedom video that was tailored specifically to the Black and African American community and really focused on specific needs within that community. So the 60-minute video described the history of tobacco and tobacco use in the Black and African American community, the health consequences of tobacco use specific to Black and African American individuals, and secondhand smoke exposure, strategies for cessation and relapse prevention, and then mobilizing the community to fight against the tobacco industry. So again, those culturally specific elements were, focus targeted, outlining the focus targeted tobacco industry marketing and how that disproportionately affected the African American community. It talked specifically about menthol tobacco products, concerns about pharmacotherapy. It added in specific religion and spiritual elements, talked a lot about the family and community infrastructure, and then again used Black and African American images and music, and really wanted to be specifically tailored to that community. And those were all infused throughout the video. And then additionally, they had hired quick coaches that reflected that community, and then were trained to really understand these specific cultural nuances. So prior to this specific cultural intervention, research found that 10 to 29% had a quit rate among African American quitline callers. The preliminary research from this study showed a 7% difference in the self-reported verified cessation between participants who received, the standard versus those that received the standard and the Pathways to Freedom video. So it did show an improvement in having that culturally targeted effort. The most recent update of the tobacco use and dependence clinical practice guidelines stress the need for additional research to determine, again, the effectiveness of culturally targeted smoking cessation interventions, specifically for diverse racial and ethnic groups. The guide did review some specific culturally targeted initiatives, like the one we just looked at, and noted the benefits of documented efficacy in reducing health risk behaviors when it was culturally targeted. They also noticed an increase in retention of information and increased participation overall. So the idea of cultural targeting or an intervention approach for a defined population subgroup takes into account characteristics that are shared by those subgroup members. And so, for South Dakota, your population subgroups are identified in your priority populations. And your work ahead of cultural humility will now be to address the shared characteristics of those subgroups within the framework of tobacco control and cessation. So on the screen, you can see a summary of some culturally targeted initiatives versus some non-targeted initiatives from research within Black and African American populations. To date, many of the targeting approaches can be characterized as kind of surface structure or peripheral. So surface might mean the inclusion of graphics and images that are relevant to that subgroup. Peripheral serves, works to increase the appeal and acceptance of the health promotion materials. So we're going to take a moment and dive in a little bit more to what we mean by those surface level interventions, and then what's meant by maybe some more deeper cultural initiatives. And research has shown that you definitely need both. You need surface and you need deep, and there's definitely more uptake in participation, retention of health information, and noted cessation when you have more deeply concentrated efforts. So there are, multiple levels of culture, and a helpful way to look at it is to think of it like a tree. So a tree is part of a larger ecosystem, one that impacts its growth and development. The shallow culture is represented by the trunk and the branches of the tree, while your surface culture or the observable characteristics are like the fruit that the tree bears. These are most notable when we think of culture, the observable elements such as how someone dresses, the foods that they eat, or the language that they speak. These surface and shallow cultures are not static, they grow, they move, and they shift in the wind and seasons of life. But deep culture, are those things that are ingrained, and it's kind of like the root system of the tree. It's what grounds you, it's what keeps you connected, and what nourishes you. So when considering tobacco prevention and control efforts, service level interventions would be things like matching the intervention materials to the preferred characteristics of the target population, such as matching the race or ethnicity of the staff to the group, or using culturally relevant settings or channels, music, food, and language. So definitely those things that we've discussed. Deep structure interventions look like the intervention we explored earlier with the Pathways to Freedom video. It is initiatives or interventions that integrate cultural, social, historical, and psychological influences of behaviors, in those priority populations. And like I said earlier, you definitely need both. And we'll talk a little bit more about that in just a moment. So on the screen, you can see some additional examples of surface interventions versus deep interventions. So when we look at surface structure, it might be something considering looking at a specific population, like whether that's Hispanic or American Indian or African American. So definitely guiding materials to that particular group. Surface interventions might look like having images that reflect that group, potentially lowering the reading level to be more aligned to what's the average reading level from that particular group. Definitely having it in different languages from those groups, whereas a deep structure might incorporate more of values from those particular groups or identified social constructs from those groups. It might be something like adding a peer component or having an ability to get feedback that's more specific from individuals from that group and having them dictate what materials should look like. So this is just an example of what does that surface versus those deep interventions look like. And again, you need both for sure. And the deep interventions are going to be those things that research has shown has a greater impact or influence on actual behavior change. So if you are an individual that says, oh, we've been doing some of these things, we've been including images, we've been changing the language, and we really haven't seen an uptake in participation or retention, those things are great. And they're definitely important for drawing in a particular group or population. But it's really when you get those deeper interventions that's where the research shows the behavior change can actually be influenced. So we're now going to take a look at how you kind of put all of these considerations together and have a culturally humble tobacco control effort, one that encompasses both that surface and that deep level intervention and really works to drive equitable outcomes. So unfortunately, there really is no specific cultural competence framework. There's actually a bunch of different ones. And, for the most part, they share similar initiatives, but some are very granular and specific to a particular disease or disease state. And then other efforts are really broad and they could, fit a variety of different initiatives. So I've taken, components of the emerging frameworks and kind of put together some specific considerations for tobacco control efforts. I did want to provide, kind of the driving force behind these frameworks. The culturally and linguistically appropriate services are those that respond to individual preferences and needs. So these services work to help improve health outcomes and decrease health disparities. So according to the U.S. Department of Health and Human Service, the Office of Minority Health, the principal standard of cultural and linguistically appropriate services involves delivering equitable care that is effective, understandable, and respectful. So the next framework that you're going to see is built upon those three key principles. Having a culturally humble and competent tobacco control effort means that you have organizational, systemic, and clinical cultural competence. Partnerships are specifically called out in the middle here, as they are the cornerstone to ensuring comprehensive and sustainable efforts. We're going to look at each of these components individually and then discuss the elements that would fall within each of these categories. So healthcare systems, policies, and initiatives are typically shaped by leaders and organizations that are doing the designing, and then the workforce that's then carrying out those designs. So there needs to be diversity of thought, background, and lived experiences at that highest level in order to ensure that initiatives are comprehensive and inclusive of a variety of realities, experiences, and backgrounds. So while great strides have been made in recent years to diversify healthcare leadership and workforce, each organization needs to look critically at their makeup and consider some key questions. So those questions are, does your leadership reflect representation from your priority populations? Does your workforce reflect representation from those priority populations? How are considerations from your priority populations incorporated into decision-making regarding programs and initiatives that are designed to reach that population? I want to read for you the quote on the screen here. It says, "If we don't have at the table people of color and the diverse populations we serve, you can be sure that policy making and program design are also going to be exclusionary as well. And we're going to continue to have disparities if we don't start increasing diversity in the health professions." So as this quote kind of suggests, if we don't have people at the table making decisions about how we're going to, particularly reach a group, or what are our programs going to be designed to look like, and how are we going to be interacting with individuals, you can bet that we'll continue to perpetuate the same decisions that have been made in the past. We have to diversify the health profession to account for all backgrounds and experiences. And again, it might not be necessarily mean hiring. I think this is where that partnership component comes in. But really, how are you getting the information from the groups that you're serving, and how are you getting information from them? And then how is that incorporated into your decision-making process? Organizational efforts for cultural competence might look like diversifying hiring practices and ensuring a workforce that reflects the audience and populations that you're serving. Another avenue, again, is like I just described, having those patient advisory boards or participant advisory boards that can help shape policies, practices, and programs. So even if your leadership team does not reflect the diversity of your community or your priorities, your organization can still bring in those with having these types of boards. Having organizational cultural competence training can also help to increase competence and awareness across the organization. And then using data and analytics to really articulate the importance of these initiatives and why you are particularly wanting to reach a population. Having that data and analytics can showcase the populations that aren't being served or where you need to have more concentrated efforts. What's most important in this work for organizations is to really set the vision and the why behind why you're doing this. The organizations will want to set context for the importance of some of these initiatives. Just mandating a cultural competence training or changing hiring practices without that set vision can really lead to poor adherence and resentment within the organization. So providing the value proposition for your organization or your teams, using data to showcase the inequitable health outcomes for the populations that you're serving, and how concentrated efforts can help to improve the lives of those that you're serving. Those are all very important and a key to having a successful organizational cultural competence initiative. The next component in our framework is systemic cultural competence. You could have a completely vested and driven organization with great diverse leadership and still not make strides with priority populations. Organizational cultural competence is definitely the first step. And then the next step would be addressing systemic barriers. Literature reviewed identifies, various systemic issues for care and initiatives that are meant to meet the needs of diverse populations. For example, poorly constructed and complicated systems that are not responsive to the needs of diverse populations, lacking interpreter services, or culturally and linguistically appropriate health education materials can also diminish, these efforts and retention and adherence to care plans from participants. So really, to address systemic cultural competence, you have to ask, what are potential barriers for my priority population? How do I collect information from those who are unsuccessful or unable to participate in a program or initiative? How do you prepare to anticipate and address those barriers? Do you have a systemic way where you're capturing what might potentially get in the way for someone to participate in a program or to understand, health materials? And then again, where do care disparities exist within the system? Or who are those populations that are adversely affected? So all things to think about when you're thinking about having a systemic cultural competent approach. So to address systemic cultural competence, you can do things like survey individuals to understand their specific needs, use information from those surveys to inform initiatives and programs going forward, engage priority populations through focus groups and inquire about how they engage with your programs and, what are the barriers that they're experiencing. We can brainstorm all day long, right? And think, it might be that. It's definitely more fruitful to go straight to the populations and ask, what's the barrier, what's getting in the way, and then work to diminish that. Data collection may also help to uncover potential systemic barriers that may need to be addressed. And again, that might be data that you get from the community or the market, or it might be data that you collect within your own populations. And then again, really thinking about how do we build knowledge about the local community, and how can that serve as a roadmap for identifying potential resources that either might be lacking in the community or uncover partners that can definitely help you with this work. So the next key component is that of having clinical cultural competence. This is the ability of those that are delivering the healthcare or the health information to understand sociocultural differences between themselves and their patients or their participants. Being able to communicate in the way that is most received by the individuals helps us to improve satisfaction, increase adherence to a care plan, increase retention of health education materials, and again, ultimately, what we're all here to do, improve those health outcomes. So when a care provider or health educator fails to take sociocultural factors into account, bias and stereotyping can result, which can then affect behavior and influence patients and participants. So questions you can ask yourself: how do you personally broaden your individual knowledge of your specific priority populations? Is training or education and cultural competence required when working with priority populations? And, what is your personal commitment to cultural humility? How do you have that respectful, humble approach? In a moment, we're going to look, specifically at more things that you can do individually to increase your cultural competence. But before that, we'll look at our last key component of partnerships. So again, the final component of our cultural competent framework, and one that is central to all the other components, is that of partnerships. So partnerships can help you to increase trust with a priority population. It can help you to gain that knowledge that you need about what's going to be important to those individuals. Or potentially it's providing training for a specific cultural group so that, your whole team can know what are the things that we need to understand. We talked earlier about patient advisory boards and how you can glean information there that can drive your initiatives and programs. Partners could potentially provide the people to serve on those boards or those initiatives, or partners can be ambassadors within the community or within the particular population for your programs and initiatives. They could help with marketing your initiatives or sharing that health education information or those materials that you've created. So really what's important here is to consider, or the best practice guideline, is that you understand where and how you can use embedded partnerships across organizational, systemic, and clinical cultural competence. So as I mentioned previously, increasing clinical or that personal cultural competence is a central pillar for a culturally competent tobacco control effort. We're going to look for a moment at how this happens on a personal level and what you can do when working individually or in small groups with individuals that are culturally and ethnically diverse from you. So I want for just a second to revisit our definition of cultural humility. So cultural humility is that humble and respectful attitude towards individuals of other cultures. It's definitely requires the effort of you to challenge your own worldview or your own cultural biases, accept the fact that you can't possibly know everything about every other culture, and really take on this learning approach as a lifelong goal and process, that you're going to be continuously learning, continuously growing, and there's always something for you to explore further or to learn more. And I really revisit this definition to show that increasing, your clinical cultural competence really requires a personal commitment to this work. And that this commitment really begins with an understanding of yourself, your own cultural worldview, and your own cultural biases. Having a culturally humble, perspective challenges us to learn from people with whom we interact, to reserve judgment, and to actively bridge the cultural divide between our perspectives. Cultural humility always begins with our own self-awareness. Once you're aware of the things that you do know, then you can be open to exploring the things that you don't know yet. This curiosity allows for an insight into an unknown world and more education on where injustices and power imbalances lie. And in some form or fashion, all of the knowledge gained through this approach can be used for advocacy to help address those power imbalances and shape a more inclusive community. And even on an organizational level, it can, lead to advocacy within your organization on why you might need to do a program differently or have different materials, or a different approach when you're serving different populations. And again, ultimately, the goal in all of this is health equity, an equitable society in which all individuals can participate and prosper. The goal being to create conditions that allow everyone to reach their full health potential. And, there are lots of things that shape and impact culture. It's important for us to understand that, kind of these four factors, and to know that there's going to be socioeconomic factors that are impacting culture and what needs to be done there. There might be geographic factors. So even though you're dealing with the same population, your approach might be different than what was done in another state or another county. There are history components that impact culture, and understanding that history is going to be imperative. And then, the politics and what's going on, within our local government, our state government, our national government, and how that is going to impact culture as well, or impact the populations that you're wanting to serve. And what are those things that you need to take into consideration with that? So knowing that this culturally humble approach begins with our own self-awareness, we really have to put ourselves in the center circle here and really think about those things around us that drive and shape our daily life, our interactions, our worldview. And then really, once we're done mapping that, consider how that shows up in our work, how that shows up in how we approach individuals. How does that influence the way that we do our work? If we were the ones trying to overcome tobacco addiction, how would the things in these bubbles kind of help or hinder our progress? And so once we've identified that for ourselves, you can definitely, gain that self-awareness of, this is going to be where I lean. This is going to be how I view, approaching tobacco cessation, or approaching, taking on a tobacco product. Like these are the things that would definitely help in this process, or things that would hinder. And I think it's really important that you take the time to consider gain that self-awareness for yourself, so that then when you're interacting with others, you don't default to that. That that's where your brain going to go, and you can lean into really that curiosity and understanding, what does this look like for other people, and particularly the populations that you're trying to serve. So when we think about that, again, what can I personally do? And how can we put kind of all of these things together that we've talked about? We, again, raise our own personal awareness and consider how that shows up in our work and in our interactions with others. And then there's this widely used model called the LEARN model. And it's used in a variety of disciplines, such as healthcare and social work, to provide the helper with tools for helping patients or individuals take action on an issue in a way that is respectful and humble of culture. So this widely used model is again called LEARN, and LEARN stands for listen, explain, acknowledge, recommend, and then negotiate. So really incorporating this into your everyday work, you really want to always start with listening, so that we can understand from that individual, what is the worldview to which they're approaching this problem, or what are the things in their life that they're sharing are going to hinder or help. Then we do our best to explain, kind of our perceptions of the problem, and try to do that in a way that is acknowledging of the differences. So we might see it this way, or health education might tell us it's this, but really acknowledge the differences between what we just learned through listening and what we know through, whether it's research or science or health. And then you come together and recommend a pathway forward. And you might have one recommendation, the patient or participant might have another. And so that's where that last piece of negotiating comes in, and really deriving something that's going to be sustainable for the patient or the participant, and something that they can actually do that's also respectful of where they're coming from. So that was a lot. And I, really want to focus on, okay, what are my practical takeaways? How do I actually do this in practice? How does this show up and what does that look like? So we're going to a little bit of time here. I think Alexis is going to set some time for us in breakout rooms to work through a case study on cultural competence and tobacco control. So as you, in your breakout rooms, what you'll be doing with the other individuals is working through that case study you received and answering the questions along the way, considering the things that you might need to do individually, systemically, and organizationally to really drive change in the populations that you're trying to serve. So I think, Alexis, do I turn it over to you to get us into breakout rooms?
Yep, breakout rooms are now open, so you can go ahead and join your small groups.
Awesome. All of it, and that's okay.
This meeting is being recorded.
Definitely, please, hope you'll take the time to, look at that on your own, but wanted to just take a moment here to see if there was anyone that wanted to share maybe some key takeaways or some next steps that you're considering in increasing your culturally competent efforts.
Definitely learning about their home life and to see what kind of support that they have. Whereas, some people want to quit on their own and they use the SD quit line, maybe privately, or they want to do it privately because, there's more peer pressure, I guess, in Native homes or, different culture homes, like of what's acceptable and what's not. So like definitely find out like the background on their home life first.
Awesome. So that's something you'll do individually when you're working with individuals, ask questions about that home life. Is that what you're saying?
Yep, and make sure that they have like some type of support system other than just the quit line, which would make it a lot easier.
Awesome. Thanks for sharing that. Anybody else, a key takeaway or next step for you in this work? Got something in the chat box here about liking the LEARN acronym. It seems easy to remember and apply in conversations. So definitely taking that forward. Thanks for sharing that. Anybody else, any key takeaway? Hearing none, I want to be respectful of your time. So I will turn it over to Hillary, who I think has some closing announcements.
Yes, thank you, Rachel. Getting some messages that it was just really good discussion. So it's always exciting to see. So just to wrap up for today, just wanted to say thank you again to everyone for attending today, and also thank you again to all of our speakers. We have tomorrow morning still from 8:45 is when our rooms will open, and we'll just kind of do some networking, but the official start time of the Institute will be at 9 a.m. to 12:30 Central Time tomorrow. So That is on Central Time. If you do have any questions, please feel free to email me. Any documents you may need for tomorrow can be found in the calendar hold. And other than that, I hope you all have a great rest of your day, and we will see you tomorrow.
You.
And
Yeah.
you should have a calendar hold for tomorrow. If you're not able to see it, let us know and we can resend it to you.